Wellness warrior friends of mine, loved ones, and fellow sisters and brothers. Welcome back. I am interviewing somebody who this is my favorite person to interview as far as just, she's so happy, she's so positive, she's so upbeat. So if you're feeling depressed, you could just watch this just because she's such an amazingly happy, positive, spiritual person. And she has been one of my greatest mentors for something that has plagued me since I could remember, and that's belly bloat. You guys have seen me talk about this a lot. So I'm Diane Kazer. I am interviewing again for the third time. I think it's the third time now, Dr. Allison Siebecker. She's amazing, and I'm going to refer you guys over to her website, which is siboinfo.com, to read all about her and how she got into this. We're going to talk about what SIBO is today. It's actually a cartoon character that I came across when I Googled it. She looks like a superhero. And actually, she and I both, Dr. Siebecker and I are both superheroes because we've conquered SIBO, and I guess we're in remission. So we're going to talk about this today and why it's so important, not only for you, but for the kids, future generations, and the prevalence, because people are going, I'm so bloated. It's like the number one thing that I hear. So Dr. Allison Siebecker, I'm going to just really quickly go through these first 3 lines of her bio, and then you guys can go into read a little bit more about her. Her passion just comes out when she speaks. Dr. Allison Siebecker has worked in the nutritional field since 1988. So basically since I was 10 years old, I'm 36 now. Gives you an idea. That's like 25 years, 26 years. She is a 2005 graduate of the National College of Natural Medicine, where she earned her doctorate in naturopathic medicine and her master's in oriental medicine. She's a medical director of the SIBO Center for Digestive Health at NCNM Clinic in Portland, where she is today, where she specializes in the treatment of SIBO. Now, she's got tons of amazing stuff beyond that. She's all over the place, all over the internet. If you guys Google SIBO, you'll probably find Dr. Allison Siebecker. You probably will find a lot of things from Dr. Pimentel, Chris Kresser. You'll even run into me. Actually, it's been one of my most popular things that people have sought me after, and I help in the treatment of SIBO, thanks to the mentorship of Dr. Allison Siebecker. So Dr. Allison, welcome to the show again.
Thank you, Diane.
And you are in Portland today, right?
I am. I'm sitting right here. We actually have sun, which I have my blinds down.
Oh, I know. Yeah, it's been hotter than crazy here lately, but we need the rain. So I always say that something really interesting is that when the planet feels something, and when the weather is dictating something, we feel the same thing. So like when the planet's dehydrated, we're kind of dehydrated. It's really interesting, this Gaia relationship that we have.
I agree.
Yeah, and Portland is where actually a lot of people have been moving, I know, over the last 10 years because we've had water shortages. People who've been working in California, they move up there. So it's probably the healthier place there to be hydrated, which actually ties a lot into the bowels, which we're going to talk about today. I was talking to my boyfriend yesterday about something I made like 6 years ago. And you have been ahead of the research with SIBO and with bowel, and the importance of bowel health for our entire health. And then what they say now is that 90% or so of our health is dictated by what's going on in the gastrointestinal tract, which 6 years ago I made my very first cleanse titled Bowel Boot Camp, and people thought I was crazy.
Well, you still might be crazy, but
crazy in a good way. So what I said, I interviewed Dr. Isabella Wentz on Hashimoto's hypothyroidism, which since you and I last spoke, I wrote a little ebook on how to reverse and heal Hashimoto's hypothyroidism and autoimmune disease. So today I'm really excited because we are going to talk about the autoimmune component, which came first maybe, and the new research. And one of the really cool things that I'm really coming to terms with this. You're a doctor, I'm a practitioner, and we can get so left field with the science and the studies that some people are going, well, language is that. So today, if we really boil down how to inspire people to get better, it's through their gut. And I mean aesthetically, sometimes like people have bloat and they just feel like they're not sexy, or they don't feel appealing to other people. And then of course there's the symptoms that come along with that come along with SIBO that like we're going to talk about today. So specifically related to small intestine bacterial overgrowth, we've already done a few interviews on this, and I'm going to have this in the show notes to simplify it. But in its simplest terms, what exactly is SIBO?
It's just when bacteria are not supposed to be in the small bowel in much quantity. It's just when bacteria move into the small bowel and colonize it. So like, the large intestine is where we have bacterial colonization. That's good. Everybody knows that. They help us, we take probiotics to help the bacteria in the large intestine. When that bacteria in the large intestine moves upward, backward into the small intestine, hangs out, that's SIBO. The other place the bacteria can come from is from the top down. Either way, the bacteria are supposed to be moving through that area, the small intestine, and when they accumulate, that's SIBO. The big problem is that bacteria, they ferment carbohydrates, particularly fiber. And when they're in the small bowel, then the food that we eat, which contains carbohydrates and fiber, can be fermented by them. They make gas. And those gases, hydrogen and methane in particular, pardon me, that was my phone.
That's your SIBO talking.
Those gases can create the symptoms. The bloating. The bloating is usually just gas, swelling out the intestines, but also they affect motility. Hydrogen seems to be associated with diarrhea. Methane is a cause of constipation, and if you have both, you could have a mixed picture. And then swelling can cause pain, and there's other symptoms that can come. So it's just when too many bacteria are in the small bowel, then there's carbohydrate malabsorption, there's gas, and there's symptoms.
Yeah. And those symptoms, I mean, I've talked to so many different people. Can you hear an echo?
I don't. Wait, now I do.
I hear a little bit of an echo. I did for a second. Anyway, Mercury retrograde. Okay, so as far as the symptoms, you mentioned constipation and you mentioned diarrhea, and this is, specifically related to the bowel. Now, I myself, before, and for the listeners, at this point in my life, I've been going through so many changes. When I first was self-diagnosed with SIBO, it was just before I went to your SIBO symposium. So if there's any practitioners listening who want to learn more about SIBO, every year they have a SIBO symposium. It's annual now, right?
About every year and a half or so, yeah.
Okay. And so I attended that symposium, and it just blew my mind because I had just gotten my test results back, and I was like, oh gosh, what does this mean? And then of course I was more interested in the topic because I wanted to heal myself, and then through healing ourselves, we have more empathy in healing others. So I was predominantly methane, and like you said, MC is I always like to think Mick, like McDonald's, like methane, constipation, but I also had a little bit of both. And so the other symptoms that I had were like my skin issues. So can you talk a little bit about that too? Do people tend to have patterns of skin symptoms too?
Well, some people do. There can be rashes associated, particularly rosacea is known to be associated with SIBO. Plenty of articles on that. But I think nobody specifically knows the mechanism, but what the theory would be is leaky gut. Is that, the bacteria are one of the things that could cause leaky gut, and then things can get through that shouldn't be getting through the cell wall. The intestinal wall lining. And then the immune system and the body can react in any way they choose on any day. And that could come out as skin, it could come out as a headache, a joint or body pain, nasal mucus. There's all sorts of things people get from leaky gut, and skin symptoms are one of them. Skin symptoms can also come from, of course, many other things, hormones and things like that, which maybe SIBO isn't the main driver then. But I think many people know that if the intestines are in an uproar, skin can be too.
Yeah, that was the first thing that cleared up actually for me is, and the reason I asked that, Dr. Siebecker, is because, everybody's symptoms can manifest differently. And this is where I have so much compassion for people, because I was looking at my medical records the other night. Have you ever done that? From when I was like, I don't know, teenager. And I went through and I noted all the different pharmaceuticals that I was on for all of the different symptoms that I had. And it was chronic. It was really bad. My first obsession with going to the doctor was because I had skin issues. I had cystic acne. I had rosacea. I had a lot of rashes all over my body. And then I ended up with an STD later on too. So I had all these skin breakouts, and I was just trying to fix myself, and I didn't know anything better than to go to the doctor and to get these pharmaceuticals, which I'm not saying that all these pharmaceuticals are bad, because we're going to talk about SIBO and treatment later on. But I prednisone and steroids and all different kinds of birth controls, because I originally took birth control because I had cystic acne, and then all different. I also took Accutane, which is, I don't know if many people know this, but Accutane is something, an anti-cancer treatment. It's chemo, and so a lot of these drugs people are taking to suppress what they perceive as not feeling beautiful. So I wanted to throw that out there because one of the reasons that I was going to ask you about too is one of the potential causes of SIBO. Could it be, the leaky gut that is brought on by the onslaught of pharmaceuticals today?
Yeah, it could be. Leaky gut, there's so many causes for leaky gut, and SIBO is just one. It's just one little possible cause in a large amount of things. Now, leaky gut doesn't cause SIBO. That, to my knowledge, there's nothing to show, and no theory I can think of where it would be that way. But leaky gut can come from very many reasons, you know. And yeah, and now here's another thing. What about drugs? Of course, drugs can cause leaky gut, but can drugs cause SIBO? That's a pretty interesting concept there. And may I just address that for a moment?
Yeah, let's go into all the causes for sure.
Okay. Well, I'll start with this sort of outer one, which is for years I've not understood how it is that antibiotics seem to precede SIBO. The reason that I don't understand it is because from everything that I know about SIBO, creating a disharmony in your bacterial balance is not a cause of SIBO. That I can see no way that it can just, that in itself can cause SIBO. And so, but yet it's clear as day, many people get SIBO after antibiotics. And so I've really wondered about this. And recently I discussed this with Dr. Pimentel, and he gave me a wonderful theoretical explanation. But before I give that to you, let me give you the main causes of SIBO.
Awesome.
And I want to talk here about the actual underlying causes in the body. Physiologically, structurally, what is going on? And there's three real proven causes. One, and that this is probably the most common, is lack of motility. So a slow motility of the small intestine. And specifically here, we often talk about this one type of motility called the migrating motor complex, or the MMC for short. And that is the movement that is meant to clear bacteria out of the small intestine in between meals and overnight when we're fasting. It's not the movement that moves food down. It's meant to clean. So that is probably the number one most common cause of SIBO is a lack of the migrating motor complex or motility in the small intestine. Second would be a structural or mechanical problem that is something like compressing or partially obstructing the small intestine so that bacteria are backing up behind this compressed area. That actually is fairly common as well. Much more common than people may think. The third known proven cause is immune deficiency, but I'm talking here about frank, overt immunodeficiency disease, not necessarily mildly lowered aspects of the immune system, like what we might see on a stool test when we see lowered secretory IgA. That has no proof. It could be associated, but there's no studies, no proof. Where the proof is when people have frank immunodeficiency disease diagnosed. Those are three reasons we know for sure. The immunodeficiency disease is fairly rare. Decreased motility is common, and although may not be known about in a person, and partial obstruction or a mechanical sort of problem is fairly common. Now, everything else, I'm just sort of simplifying things here, but everything else would be, most of what people think of as causing SIBO would be risk factors, and those are risk factors that could cause those things I just described. So probably the most common cause of SIBO is getting food poisoning, which is also called stomach flu by some people and traveler's diarrhea by others people, and the medical term is acute gastroenteritis. And this is what Dr. Pimentel has been working on for years to understand. And I'll just explain it briefly because then I can go back to that antibiotic thing we were talking about and link it in. So when we get food poisoning that is specifically caused by bacteria, those bacteria are pathogenic bacteria and they have virulence factors, they have toxins, unlike the normal bacteria that are our friends that live in our large intestine. So these bacteria release their toxins, and they all have the same toxin, which is called CDTB for short. And this toxin looks like a protein on our small intestine nerve cells that's called vinculin. And then an autoimmune reaction can develop, cross-reactivity, and the immune system can attack our own our own nerve cells because they think that it's that toxin, and friendly fire, so to speak. And then we're destroying these nerve cells that perform that migrating motor complex, and then the motility goes down, and then SIBO can develop because the bacteria aren't being cleared out. Now, this is really phenomenal. I'm saying it out like it's nothing. This is absolutely phenomenal. It's taken Dr. Pimentel at least 10 years to figure this all out, article after article, testing this theory, figuring this out. He has now developed a test that can specifically test for this, and it's called the IBS Check test. It's a blood test, and it's available through Commonwealth Labs. And what it's checking for are the antibodies to the toxin, CDTB, and to the vinculin protein on our small intestine nerves. So if this test comes back positive in somebody, we know two things. We know that they got their SIBO from food poisoning, and we know, most likely, and we know that the reason that they have SIBO is because their motility is decreased. So that's a very helpful test to run as a screen in people. Okay, now, where this comes back to antibiotics is very interesting. So I asked Dr. Pimentel, how could it be that antibiotics could be causing SIBO? Because if you kill off some bacteria in the large intestine, that does not necessarily affect your motility. It doesn't cause a partial obstruction. You know, I don't get it. And he had a great theory. He said, well, what can be is that you could kill off enough of the good bacteria that could allow C. diff, Clostridium difficile, to come out, but maybe it's growing to a level that is not fulminant. When you have fulminant C. diff, you have C. diff antibiotic-induced diarrhea. It can cause diarrhea, but maybe you don't even really get that level. But what happens is there's enough C. diff. It turns out C. diff releases CDTB toxin.
Wow.
Yeah, so I've seen this in many people who get fulminant C. diff that they then get SIBO, and so I thought I knew that C. diff probably does the same thing that food poisoning does. Well, it was confirmed some time ago, C. diff does have CDTB. So possibly, maybe you're getting enough C. diff to release the toxin and trigger that same autoimmune process. And the reason I'm saying it like that is because many people who have had SIBO come after antibiotics never got C. diff colitis, never got C. diff diarrhea. So, you know, we have to think a little outside the box here. Maybe there was enough C. diff rising in their large intestine to release this toxin. So, and then the other thing with antibiotics to think about is, well, why did a person take them in the first place? Could there have been you know, what was the reason? Could there have been something else that was the original illness that was like food poisoning that could be assaulting somehow the body? That, you know, I'm not sure what infection it would be, but so anyway, that's an explanation for that. And so there are many ways that, just going back to the motility piece, that a person could have their motility be decreased, not just food poisoning. For instance, there are many diseases that affect motility. And I know you wanted to talk about one of them, which is hypothyroid, but another is diabetes. And that's, there are forms of diabetes that are autoimmune, but there are forms that are not. And the damage there comes just from sugar being in the bloodstream. It can enter into nerves without any gating system, and too much sugar can actually damage the nerves, and so that's the nerve damage that comes from diabetes. So there are diseases that can cause this sort of deficient motility. Also, the muscles, any disease that could harm the muscles. There are many, many diseases that destroy and harm muscles, and then you wouldn't be able to do the propulsion. So there are many ways you can have your motility go down. Many ways, and there are many ways you could have obstruction. Some of the most common would be, and I mean partial obstruction here, would be adhesions, which are like scar bands that form after inflammation or infection. They're a healing process, and they could be compressing the small intestine. That's very common. I've reported a case at the last SIBO symposium of a patient who had endometriosis, where that's where there's bits of uterine tissue that are outside of the uterus, often coating the intestines and the abdomen, and they swell on the cycle of the menstrual cycle, and the swelling can compress, and then them being outside the uterus is an inflammatory process, and then adhesions can form. So it's both the tissue itself and adhesions, which can now obstruct the small intestine in cyclic bouts. There's so many ways that people can have these problems. So that's enough about that. I don't want to go on and on forever.
Wow. God, no, I mean, my nose, my hand is all sore from taking a one. I mean, that pretty much that's preparing people for what other questions I have. This show, you know, of course I'm biased. I have some female questions, and have been asked, because I'm in several groups where, you know, these people who are parts of these groups that I'm in are so on top of this stuff, and they're asking great questions. And the one thing I want to do is sort of bring a lot of people back down to earth, because the research that you guys are doing is so, I mean, just what you just said blew me away. And it just shows us that we really have just a little tiny snippet of insight into what's going on in the gut. And you know, we've got 100 trillion guys down there that we're more bacteria than we are human. And so what are these bacteria doing inside of us, and what are they releasing? And you mentioned one, I want to do two things with what you just said. I want to first create like a visual for people. So I love the whole, you know, the street sweeper. I don't know if I stole that or if I made that up, because I'm such a visual person, but I want people to see, you know, they know what they feel. They know that they feel this 3-4 month pregnant bloating feeling. Sometimes when they first wake up in the morning, sometimes throughout the day after meals is more prevalent, sometimes after they eat certain things. And we'll talk about that too. But they get this, all they know is they look down, they go, oh my gosh. And if they're a male, they're like, when am I expecting? And so, I'll never forget, I was at Pirates of the Caribbean at Disneyland one day, and I just looked down and I was like, what did I just eat? And I showed my friends and I was like, look, because I don't really care.
It's awful. I've had that my whole life. It's just awful.
I know, me too. And I used to think it was just super funny, you know, comparing bellies with my dad, but it's not funny. So we'll talk about, actually in our future, we're going to, Dr. Siebecker and I'm really excited about this. I asked her before the show if we could have one specifically for the moms, or the aspiring moms, or the moms that have babies, or anybody who has babies, even the dads who are wondering. So anything that has to do with children and SIBO, pregnancy and SIBO, except breastfeeding and SIBO. We'll do that in the very near 3 weeks. So maybe you look pregnant, but maybe you're not pregnant, and we'll talk about that in the future. But what I want to walk people through is, especially, you know, now these diets say eat every 3 hours, you know, snack in between, stoke the fire. And so now we're talking about, you know, these bodybuilders who've set this stage that you got to stoke the fire, you got to keep feeding the body so that there's fire, and the fire keeps happening inside to burn fat. But that doesn't really work with SIBO. So can we walk through why, you know, we've got these, you know, we eat, and then the small intestine starts to absorb the vitamins and then and the nutrients, and then it moves down to the colon to get further broken down in processing, but might be feeding the wrong things in the process. And then, you know, maybe we could talk about like a functional street sweeper and a functional GI tract, and then what might be happening in the case of SIBO.
Well, okay, so just briefly, the way it's supposed to work, you kind of just described. The food comes in. Just very briefly, we have to chew. We have to remember that we have to chew. We were given teeth for a reason.
Right. I say like 25 times if it's meat.
If we didn't have the teeth, then we'd be like babies, and then we'd have our food pureed for us. So we got to chew it up. So that comes in, goes down to the stomach, breaks it apart there. More enzymes and crushing and things happen. When it gets into the small intestine, that's when we are absorbing. And that's where we don't want bacteria, because if the bacteria were there, they would then steal the nutrients. But without the bacteria, the nutrients go into us. However, one nutrient won't, and that's anything that's fiber, which is a large category of food, actually, larger than most people are aware. That is indigestible to humans because we don't have the enzymes to break it down. And this is on purpose. It goes down into the large intestine where the bacteria do have the enzymes, and then they break it apart, they eat it, and they digest some of it for us, make some nutrients that then we absorb in the large intestine. So it's a wonderful system. They make some gas down there in the large intestine because bacteria always make, almost all bacteria make gas out of the food that they eat. So it's not us making gas, it's them. And that is just a moderate amount. Everybody has a moderate amount of gas that will leave their body, often without them even knowing. It's not like they're even having flatulence. It's just a normal process. Just sort of comes out. That's what's normal. So with SIBO, the difference is those large intestine bacteria are, in most cases, are now moved up into the small intestine. So when we eat the food, they're right there. The fiber that's in our food doesn't even have a chance to move down to the large intestine. And that gets eaten right there in the small intestine. And also the food that isn't even fiber, the food that we're supposed to absorb, like starch and all the other foods that we could normally digest, they get a hold of too. So they get a smorgasbord, and they get a feast, and then they make all this gas. Then the gas is all the way high up in the small intestine and has all this farther distance to get moved out of the body. Sometimes it will come out the top end and will have a lot of belching. SIBO can have a lot of belching. Sometimes, a lot of the time, it just gets stuck there. So the bloating seems to be from there's more gas because bacteria are eating more food than they normally would, and also the gas is in a location that isn't the easiest to get out. It's right in the middle of the body. The small intestine is like 22 feet long. The large intestine is like 3 feet long. So you see the difference there. So then it has all this way to travel, and there's already deficient motility. That would be, for a lot of people, the cause of SIBO. So the gas can't get moved out. So we've got a real problem here. Now, stepping aside and going to the street sweeper, the migrating motor complex, when you finish eating and the meal goes down to the large intestine, which may take 2 hours to get down there or a little longer, then at some point when you're cleared out of the small intestine, the migrating motor complex turns on to clean up after you. It's like what Dr. Pimentel says, it's like washing the dishes after you're done eating. And so it comes to sweep any food residue, any of the digestive secretions that came out that are left over, and any bacteria that's hanging out there. And it comes out between the meal. And it takes about 90 minutes to run through its full cycle through the whole small intestine. So this is recommended that you don't eat when you have SIBO, and probably for general health anyway, to allow your body a chance to clean up after your meal. You don't eat for, actually, Dr. Pimentel has changed it to 4 hours, and I've noticed a difference between meals. It says I've noticed a difference in my patients from the 3 to the 4 hours. It does make a difference. They feel better by waiting 4 hours. And that just gives a chance for the washing up, for the cleaning. Now, if somebody was on a regimen where they were snacking and eating in between, you still have your nighttime fast when you're sleeping to clean your intestines out. And many people have eaten in the middle of the day with snacking for various reasons and don't have SIBO. So because you really need something to go wrong to get SIBO. You've got to have something affect your motility and really mess up your migrating motor complex, stop it from working. And I don't just mean in the day, that would mean at night too. Or some sort of partial obstruction. There's something really has to be wrong for you to get SIBO. I don't think just snacking would do it. However, it's definitely healthy to not snack. But this is a problem because a lot of people have low blood sugar and then they have to snack. And this happens to so many people. We have competing treatments for our competing illnesses.
Yes.
This happens to many people on many things. And so, you're not alone if this happens, and you just do the best you can do. So if you feel you can't make it 3 hours without eating, then you do what you need to do, and then you treat the SIBO, and you do things to help your migrating motor complex, like prokinetics. You do what you have to do. No,
Yeah.
We don't all get to run perfectly here. So.
Yeah, and we'll talk about some of those tools later too in terms of treatment, because I know enzymes are one of them. Prokinetics are certainly one of the biggest ones in terms of SIBO anyway. And that's the thing is, even Dr. Dan Kalish, I think I was interviewing him or I was listening to him being interviewed by someone else, and he was saying that like 95% of practitioners, I would almost venture to say like all of us have, like, where do we start? Someone comes in and they have like 10 different things going on. It's like, oh, this is the maze. It's so difficult. And this is why people are getting frustrated because, they're just getting a pill for every ill versus getting to the root of things. So this is why I really like talking to Dr. Wentz of Hashimoto's hypothyroidism, because she's talking about getting to the root. This is why I love talking to you and the new research on SIBO, because we're talking about getting to the root and how the roots can be different for each person. So we need to find out what, where these things started before the tree started growing these bad branches and the leaves were poisoned and don't look their greenest. So
let me mention that just briefly. Hold your thought, but let me mention that this is a hard thing for SIBO because it is so new in it's not new in its conception, and of course it's affected humans throughout history, but it's new in our medical attention and focus on it. And so a lot of work still needs to be done, and thank God for all the work Dr. Pimentel is doing. But for instance, to find out if your migrating motor complex is deficient or your small intestine motility, there are various tests a person can use, but there's really just one that really checks this, and that's called antroduodenomanometry, and it is inaccessible. There's only a few locations in the whole country that offer it, and it's expensive and it's invasive. So this isn't just a test you can go to your local office and get done, and that's a problem because we need to know what is wrong. You know, is it the migrating motor complex? Next thing to think about would be, is there some sort of mechanical obstruction? One thing I didn't also mention is little non-draining pockets can cause this problem, like small intestine diverticuli. How do we see inside the small intestine to see if it's being compressed? The best way that I know is with a barium small intestine series. Barium and then X-ray offers radiation into the body. Many people do not want to do that test. That is an easily obtainable test, but many people are opposed to it. That one's a lot simpler to get than the antroduodenomanometry, but I'm just saying it's not the easiest walk in the park to figure out, to actually test for and figure out the true underlying causes of SIBO. And we have advances we must make basically to help everyone. They need to be made, you know, so we can actually know what the problem is. Because when we know what the problem is, two things happen. The real underlying problem. First of all, it affects, we want to treat that. We want to know if we can treat it. And it really affects our whole, maybe it's just one thing. It just really affects our treatment. What are we going to do? What's our strategy? And all of the treatments that we have for SIBO currently are focused not on the underlying cause. They're focused on just removing the bacteria out of the small intestine so you can relieve those symptoms and have a happier life. But taking antibiotics, whether it's herbal or pharmaceutical, they don't fix the motility. They don't fix a partial obstruction. So we're at a place right now that's better, you know, with SIBO, that's better than just taking a laxative or an antidiarrheal, but we're not where we need to be.
Yeah, and that's what people need to understand, is that this is we're all walking a path together, and we are part of the research studies because this is so new. And so accepting that the answers are not all there. And I think this is a lesson, not just for SIBO, but for life. You know, we won't ever have all the answers, really. And science has kind of spoiled us with these studies, you know, doing these studies, and those studies prove that these statistics, but you can't prove everything. There's a lot of things that we just can't. And so just accepting that and accepting that where you're at right now is perfect, and that, you know, SIBO is a blessing. I always say that cancer is a blessing too. And I wrote a blog on this yesterday because, you know, we could be living our lives so quickly. And for people who also have SIBO, like myself, I notice when I'm not breathing, when I'm short of breath, I'm not present, I'm not paying attention, I'm moving too fast, as fast as my feet can't move as fast as my brain is. And the shallow breathing also can bloat you. So there's a lot of things that can bloat you, you know, but we're talking specifically about SIBO. But I'm blown away.
That's a very, very good point, actually, because one of the main initial theories on bloating was swallowed trapped air, which for many people who've bloated for most of their lives, like myself, we get annoyed at a theory like that. But it's true. People can experience that from it. I'm sure people drink a bunch of soda, or you shallow breathe, or maybe you're eating soup with slurping, and then you're bloated, you know, and then you might have to burp. You know, it's like, it actually can happen. So there's many, many things to think about here. And also about the rushing. When our nervous system is in the sympathetic dominant phase, we are not able to do our digestive processes. Our migrating motor complex turns off, and our hydrochloric acid, our stomach acid, turns off. We can't secrete it. We can't secrete our enzymes. So just remember that when it comes time for meals, try not to rush and try not to worry. And I'm saying this for myself too, because rushing and worrying are ubiquitous, right? And near impossible, particularly worrying, is near impossible to stop, but we should try. And at meals, just even, like you said, get present. Just take even one conscious breath to ground yourself and slow down and think about what you're doing.
That's the hardest thing for me to say to some of the patients and clients that I work with, because I work with a lot of local doctors, patients here, MDs and chiropractors and estheticians and such. And I have to remind them of what, like you just said, I've had to remind myself, is that we are living in such a fast pace. And for me, it's I don't know, I've been this way for a long time, but then I went away from it, and then I came back to who I really am. Like when I was a child, I was this way. It's when I sit down and I eat, I don't really want to talk to people. I literally just sit there and I'll take a deep breath, and then I start eating. And when people ask me questions and my mouth is full, I just kind of look at them and I'm like, I'm chewing. Interrupting me. And it's not like, I'm not trying to be rude, but I do it all the time. I'll just point to my face and then they'll still keep looking at me. Like, no, you don't understand. I'm not going to have a mouthful of food and just spit it all over you when I answer, because I literally, and I've always had kidney issues too, which is we always have problems taking a deep breath, and autoimmune disease, kidney disease in my family. So we have a lot of that as well. And we'll talk about autoimmune disease and SIBO next. But literally just sitting down with your food and having one bite, putting the fork down, whatever that is, taking some, chews, maybe 25, like I talk about my warrior cleanse, which was designed to reverse autoimmune disease or put you into remission. We talk about SIBO in there too, but just take a breath and just sit with your food and really interact with the tastes of them, what's going on. Because like Dr. Siebecker said about, if you're in this fight or flight state, then your body is perceiving run away from something that's stressed out, chasing you behind here, and it turns off digestion. And hypochlorhydria, not enough stomach acid, is one of the upstream issues with SIBO, because HCl will text message your pancreas to release enzymes, to release all these other things downstream. And so if you don't have the fundamentals down, then what's the point of going in and getting all these tests run and changing your diet and maybe not really eating real food for months at a time? So start with the fundamentals first. And I'm actually going to include that in a guide that I'll have downloadable. By the time you're watching this video, it'll be there for you. But you'll want to make sure you get some of those easy things checked off first before you go into all this crazy, barium testing and whatnot else. It's invasive, putting things into your body and probing and taking samples and whatnot. So
nutritionists are famous for saying that if they just get their patients to chew their food, more than 50% of those people who have IBS, their IBS is cured by their just chewing their food. Now, there are plenty of us that just chewing your food does not take care of SIBO.
Exactly.
But a lot of people have IBS symptoms because of the fundamentals are lacking.
Yep. Okay. So we covered that for sure. We got to always make sure you cover the fundamentals. So, so we've got different people who are watching this. There's some people who are just new at it. There's some people who are more basic, and just the visual that you just mentioned about the migrating motor complex and the street sweeper. I guess a funny analogy would be like you invite your housekeeper to come over, and she's normally there for an hour and a half, and you just had a big barbecue on Sunday. She's there on Monday. She comes in, she's there for 10 minutes, and you're like, no, you have to leave now. You're done. And she's like, wait, I didn't clean anything. And so
she comes in when you're throwing another barbecue.
Oh, yeah.
And she's like, how am I can't, where their sink's already full.
Yeah. But why are you stoking the fire again? My body, person told me that I should be eating more, having more parties. Okay. Yeah. That's a perfect analogy. So guys, that's sort of the funny visual, right? Always have to think, oh yeah, that doesn't make any sense. So it's the same thing as if you're putting more food on top of the food from before that you haven't even digested, and that's where bugs start to grow. So you mentioned, I want to just get clarification for the nerds out there like myself. What is the CDTP? What is that, the analogy or the acronym? What does that stand for?
It stands for cytolethal distending toxin B.
Wow. Okay. And I mean, I guess it's possible that some of these other superbugs too could be off-gassing the same thing too. Yeah.
Yeah, I don't know every single bacteria that has that toxin, that releases that toxin, but I know all the bacteria that cause food poisoning have it, and I know C. diff has it.
And C. diff, just for the listeners, how do people get C. diff?
It's a normal bacteria that lives, it's considered an opportunistic bacteria. It lives within everybody's intestines, large intestine. It's called Clostridium difficile, and you get it when you disturb the bacterial balance. So you, like for instance, with taking antibiotics, Clostridium difficile is not killed by most common antibiotics. So you take an antibiotic for a urinary tract infection, for a sinus infection, something like that. It kills other bacteria, but it doesn't kill the C. diff. And then the balance is thrown off. Relatively now, there's more C. diff. And before, the other bacteria were keeping it in check, but now it gets a chance to sort of overgrow in the large intestine and release its toxin.
Yeah, and so, we'll talk about, oh, sorry.
That's called antibiotic-induced diarrhea. It's almost always due to C. diff.
Okay, cool. And we'll talk about too, people normally ask the question, okay, well, if there's more bad stuff in the colon and there should be more good stuff in the colon, then can't we just add probiotics, and what type would be, most effective in the case of bloating and SIBO? And we'll talk about that during the last part of this show with treatment. So I want to also take a step back to what are today anyway, ancestors are probably a little different because they were eating more Neolithically, Paleolithically. What are the things now that are causing people food poisoning the most that we have now proven in studies?
Actually, vegetables. Vegetables actually seem to have seem to have a higher rate. This was a few years ago when I looked at this, but everybody thinks about, raw dairy, because the Weston Price group has always been, which I'm a part of, is always so positive on talking about raw milk, and everyone's afraid they'll get food poisoning from raw milk, but actually it happens from vegetables most commonly, and sometimes meat, like Jack in the Box. You remember those famous things where certain restaurants are giving food poisoning, but really I don't actually think it's as much about what type of food, because food poisoning can come really in any food item. It's more about the establishment, the cleanliness issues, and I think more than anything, traveling. People, we have a much more international world now, and that has increased the incidence of food poisoning. People going to other areas where they're exposed to things they're not used to, and then the sanitation levels are sometimes not so good. So I think that's what's increased food poisoning more than anything. The other thing is, people get food poisoning quite commonly from their local restaurants. I mean, this is tough. How do we not get food poisoning? If you knew ahead, you wouldn't eat there, or you wouldn't. We don't have a future vision of this. I don't really, this is a hard question. I don't know how to answer. Some people choose to not eat out very much. That's not going to work for a lot of people, and it's a lot of people's major enjoyment in life. Yeah. But yes, when you don't eat out as much, food poisoning levels go down when you prepare your own food and you're handling your own sanitation. So I don't really have an answer for this. It's an issue.
It's pretty crazy, and that's where I say, it's not about rooting paranoia. It's not about scaring you. It's about awareing you. And so, prevention is, what is that quote again? Prevention.
Oh, I can't remember. Something like 4/10 or something.
1 ounce of prevention is worth 500 elephant tons of disease. I'm such a dork. I'm so bad at quotes. I mutilate them all.
Here's the other thing. It might help. So that people wouldn't be too frightened. The rate of getting SIBO or post-infectious IBS, as it has been called, from food poisoning is around, on average, 10%. Now, there are studies that show higher amounts, and there are studies that show lower amounts, but we'll just say an average right now is 10%. So 90% of the time when somebody gets food poisoning, they're not going to go on to develop SIBO. So and that makes sense, because people get food poisoning. Most everyone has had it multiple times. And we all know lots of people who've had food poisoning and they do not have SIBO. So.
Right. And I know for me, I've traveled extensively, so I know those things have probably contributed, and I wasn't paying attention to my diet for years and drank lots of alcohol, and I was a college girl.
I will say this, that drinking alcohol or eating a poor diet is not really a cause of SIBO. Mm-hmm. I mean, you really have to have your migrating motor complex damaged, or some sort of partial obstruction, or, it's because the world is full of people who drink abundant alcohol and don't eat a good diet, and they don't have SIBO. So certain something has to affect the physiology, and just eating crap food isn't going to do it. I'm not saying you should eat crap food. I'm just saying, I just want us to be accurate about what causes it.
Absolutely. So what things could people do, if people, even for SIBO sufferers like myself and you who have had this in the past, and we are more sensitive potentially to reinfection or rebloating. So what things could we do for prevention, with things like activated charcoal and taking those at meals that we're not sure of, or like washing our vegetables, like buying from local farmers that we trust? I mean, like, what are some?
All of that is perfect. All of that is perfect. Of course, if you're cooking your own food, most everyone is rather cleanly and sanitary with that. But when eating out, you could take like an herbal antibiotic when you're eating out, of which there's many. You know, I mean, allicin, which comes in the product Allimax and Alliultra and Allimed. That's a good option. A lot of doctors recommend that, natural doctors. There are plenty of other herbal antibiotics a person could take. Charcoal's a fine idea. The only thing with charcoal, though, is that it does absorb nutrients.
Right.
So it's a little bit of a tough one. You know, I mean, it is used for food poisoning in the emergency room, actually, because it absorbs toxins and things. But you would want to space it at least maybe 30 minutes before your meal or maybe 2 hours after your meal so you can get your own nutrients.
Good point. Yeah, whenever I go to sushi restaurants, I take activated charcoal 30 minutes before. Before I leave the house, I take it, I get there, and I'm just never
brilliant.
sure.
That's exactly the type of thing you can do if you're concerned, but particularly people who've already had it. That's something Dr. Pimentel says, is if you've already had SIBO, a key thing is to not get food poisoning again. And then it's like, well, how do you do that? And it's these types of things, because that can really reactivate the whole autoimmune process.
Yeah, and the botanicals that you just mentioned too. I mean, let's say that somebody wants to do it naturally, and they like, you know, I know a lot of people are like, gosh, I spent so much money on testing. I'm kind of at that point where I don't know if I should buy more supplements or can I just do this naturally? So, you know, even if somebody, let's just say, chewed a half a clove of garlic, which is what, you know, the active ingredient is allicin, or let's say they had, and that's why they have sushi served with ginger, is because ginger is another one. So things like that, or would those be?
Even sometimes alcohol, you know, can kill, which is, you know, so you drink sake with a sushi. I will say one thing though about the garlic, that being a high FODMAP, it is very fermentable by bacteria, raw garlic and garlic in general. So that might not be the best match for someone who's had SIBO. That could really cause bloating.
Yeah, that's also something that I was going to ask today, but I kept it out, is that it came up sensitive in my sensitivity test. And so I was like, well, I shouldn't have it. But then it actually became one of the things that I did so well with allicin when I took it. So it's like, well, yeah.
Allicin is a little different because that allicin is the it's one antibacterial ingredient, like a constituent within garlic taken out. So it's not whole garlic, which actually many naturally minded people might be bothered by. It's not a whole herb. It's this one constituent taken out that's antibacterial. So many people who react to garlic do not react to allicin. It's acceptable for them. Good
to know. Okay, so I really want to focus to the two things I was really excited to talk about. Actually, there's three things, and actually two of them are in the treatment piece. But I really wanted to talk about, because I'm becoming a lot more active in the Hashimoto's hypothyroid community and autoimmune disease. So I want to shift gears and take a couple of minutes to talk about the autoimmune disease component and maybe, you know, Hashimoto specifically, and then we'll talk the last 5 minutes or so, maybe a little bit longer if you can, on the treatment options, that new research, and then about three, you know, really easy takeaways that people can start with for advanced and basic, and then all the guides will speak for themselves. So can we talk specifically about Hashimoto's hypothyroidism? And what people are saying now is that a lot of SIBO patients, people who have been diagnosed with SIBO, or maybe they've never been diagnosed, but they have been diagnosed with Hashimoto. So can we talk about that real quick?
Yeah, so there's always been a concern, or for quite some time, about this relationship between SIBO and hypothyroid, because when there's hypothyroid, gastrointestinal motility goes down, and it's very common to have constipation. And it is a well-known fact that when you have hypothyroid, you have hypomotility. I don't know of any studies that specifically say it's the migrating motor complex in the small intestine, but it sure seems that it could be, or, you know, likely, because there was a study done by Dr. Loretano in 2007 on SIBO and hypothyroidism. I don't think he specified Hashimoto's, but it was overt hypothyroid, and he found that 54% of those with hypothyroid tested positive for SIBO. Although that test was with the glucose breath test, which often underestimates the true prevalence of SIBO because it only tests the first 2 to 3 feet of the small intestine. So, in fact, the number might truly be higher than 54%. And when he compared that to those who had normal thyroid, it was like a 2%. So it's very statistically significant. Absolutely, there's an association with hypothyroid and SIBO. Now, what I don't know is, the speculation is that hypothyroid is causing SIBO because it's causing hypomotility.
Right.
But I don't know that that's true. But that's what people are wondering and thinking.
Right, logically for sure.
Yeah, right? It sure makes sense. Now, the other thing that Dr. Loretano found, which is interesting, is that when the, well, basically what he found was that the SIBO, the bacteria, are not influencing thyroid hormone. So it's not like SIBO will now affect your thyroid hormone. He did not find that association. It was more that the hypothyroid would slow motility and allow the bacteria to accumulate.
Right.
The other thing a lot of people have found is that if you correct the thyroid hormones and bring them to their normal levels with medication, that constipation gets better. That's a known thing that often happens in hypothyroid. However, I will say that I have not seen that in my SIBO patients. Lots of my SIBO patients have hypothyroid. I mean, hypothyroid is so common anyway.
Yeah.
So, but that might be because I see this often. It seems as though when someone has SIBO and when you correct the motility, like with a prokinetic or maybe with thyroid hormone, or maybe because maybe a person got SIBO through intense period of stress. I've also seen cases like this. And intense stress will stop all your gastrointestinal. We talked about sympathetic versus parasympathetic. Stop all your gastrointestinal movement secretion. That could allow SIBO to occur. But now let's say the stress is gone. Let's say the thyroid is corrected. Let's say you're on a prokinetic. Your motility is occurring now. I have not seen that correct SIBO. It's very interesting. It seems as though now maybe that motility can't deal with the overwhelming amount of bacteria that's there. So then you still need to kill that bacteria, eradicate it, decontaminate the small bowel with herbal antibiotics, or elemental diet. And then now that motility has a chance to keep a clean small intestine clean. You have to clean it out first. You have to do the deep. You got to get that house cleaner to come in and do a deep clean. You know how when they come and they charge you like 3 times more than normal, and then they come in. I have done this a few times. And they come in for like a full day and clean your house. I think that's what we would associate maybe the antibiotics or herbal antibiotics, something like that. So that's interesting to me because I have so many patients that have had hypothyroid. They're on the proper medicine. Their thyroid levels are normal, and they are still struggling terribly with SIBO.
Yeah.
But at least we have a good chance. I do think you've got to get the thyroid corrected, dealt with in some way, or you're going to have much harder of a time. I mean, you can always use prokinetics, but heck, if you know something that's lowering motility, then address it.
For sure. I know that when I fixed my thyroid and I went into remission with both SIBO and Hashimoto's, I feel like they both kind of peaked at the same time because I felt like my food was sitting. If I ate anything that was nutrient dense with, more fiber or more, or let's say meat, even for a lot of people I work with, they just feel like it's just sitting there. And so when my thyroid hormones were operating effectively, I feel like my migrating motor complex was operating effectively, and I was taking enzymes and a whole bunch of things to help assist the breakdown of all the nutrients. And it's like 60% of our thyroid can, T4 to T3, the active hormone, it is, help us with the metabolism and feeling warm and sex drive and all that stuff. That's in the Dr. Isabella Wentz interview, if you guys want to tune into that. But 60% of that thyroid hormone is converted in the liver. And so if we've got SIBO and we've got congestion there and backup of stuff there, then everything is connected, right? So maybe we don't have all the research yet, but it's so connected. And I wanted to ask, moving into treatment, that there's amazing things happening right now. And I want to keep out some of the things that we've already maybe talked about and I'll link the first interview that you and I had below. And it's probably some of that information may be outdated. So I'll refer them to siboinfo.com so they can see more information about, rifaximin, Meissen, and all that stuff, which is the antibiotics. But I specifically want to ask, because you've mentioned so many times prokinetics, people are probably at this point going, well, gosh, she sold me. Where do I get these prokinetic things?
Okay, so just a brief overview. Prokinetics are also called motility agents, and they're meant to meaning for, and kinetic meaning movement. So they're meant to stimulate movement, and we use them at very low levels usually because we're just trying to stimulate the small intestine, the migrating motor complex. How well each prokinetic stimulates which area might vary. if you go too high on a prokinetic, or if it's not the right one for you, it could stimulate the large intestine and then cause a bowel movement, and we are not trying to do that. This is a question almost every patient has. Gosh, I've always had diarrhea. I can't take a prokinetic, can I? Yes, because we're really just using them at low dose to stimulate the small intestine, and they don't produce diarrhea in that circumstance. So what they're used for is to stimulate the migrating motor complex, since most people are deficient in that motility, and that's why they have SIBO. Even if a person has sort of like a partial obstruction, they may be of help, just to help move past the obstruction. Although that is something, if you have an obstruction, you'd want to talk with your doctor about, whether you should use prokinetics or not. So there's 6 that my fellows and I tend to use, and I'll go through them all briefly. But I just want to say it's important to know that prokinetics as a category have a lot of pharmaceuticals in them that have been dangerous, and therefore many doctors hear the word prokinetic and to them it equals danger, and then they are opposed to the whole category without being fully educated on the safe prokinetics. So I want people to know that, because you should be prepared. If you go to your doc and ask for a prokinetic, they might freak out, and this is why. And they don't even know that there are safe prokinetics. So the 3 pharmaceuticals that we tend to use are erythromycin, E-R-Y, erythromycin. This is actually an antibiotic, but we use it at such a low dose, usually between 50 to 60 milligrams at night before bed, that it does not have any antibiotic activity. It just isn't going to work that way. This is a well-known prokinetic. It's used for gastroparesis, or partial stomach paralysis, which, by the way, you talked about the meat and the food just sitting, not going down. That's a primary symptom of gastroparesis, because the stomach has its own migrating motor complex. It feeds into the small intestine, and so it may be that is just not working well for you if the food is sitting. So prokinetics are the primary treatment for gastroparesis. Erythromycin. The next one would be prucalopride, Prucalopride. Prucalopride brand name is called Resolor. This is not yet available in the United States, so patients who want it have to obtain it from Canada. It comes from the UK. It's been used in Canada and Europe for 20 years. Many good studies. It's very safe, but it's not easily obtainable in the United States. When this is used for SIBO prevention, we use it at a 0.5 milligram at night before bed, so the pills will need to be cut, just like erythromycin. However, if we needed stronger dosing, we could go up. The studies on Resolor, prucalopride, were even up to 4 milligrams, and they were studies on constipation, actually. Okay, then we have low-dose naltrexone, which is called LDN for short. And this is also a pharmaceutical. It has a lot of positive off-label uses, prokinetic being one of them, also for depression and autoimmunity. It helps to balance the immune system. Good choice for anyone with autoimmunity in their picture with SIBO. However, it does not seem to work as a prokinetic in everybody that it's given to. And Dr. Weinstock did the studies on this, and he found that a good third of patients, it just wasn't strong enough for. And I find that too. So it's a great thing to try, but know that it might not be strong enough, so that if it's not working, then you may have to try something else or add something in with it. Those are the 3 pharmaceuticals that we tend to use. The 3 naturals we tend to use are Iberogast. Iberogast is a herbal combination from Europe. Long history of use, at least 40 years of use, with over 47 studies. So very, very safe product. The SIBO population is extremely sensitive, by the way, to supplements and medicines. And so even an intensely safe, low side effect product like Iberogast, people can react to who have SIBO. They're very, very sensitive. So, but it is a very low reactive product in the studies. That has proven prokinetic abilities. It's been used for dyspepsia and gastroparesis. None of these have been studied for SIBO except LDN. Okay, that's excellent. I was using it at 20 drops at night before bed, but a colleague of mine, Dr. Mona Morenstein, found 60 drops was better. So I think 60 drops at night before bed would be the better dosing. By the way, for LDN, the dosing is 2.5 milligrams for those who have had diarrhea and 4.5 for those who've had constipation, either at night before bed, or for the constipation folks, it could be split into a morning and PM dose.
Great.
The last two are straight ginger, and that can be used at around 1,000 milligrams at night before bed. Ginger is a proven prokinetic. People know about that from nausea, using it for nausea and morning sickness. It can particularly helps gastroparesis or stomach emptying. And the other one is Modal Pro. It's a product by Pure Encapsulations that has ginger in it and a few other ingredients. This product is meant to stimulate the large intestine as well. So just caution with people who've had diarrhea. It might be fine in them because we usually use it at about 3 caps at night before bed. That might be okay, but play with the dose if by chance that happens. And the two other things to know with ginger and Modal Pro, which has ginger, is that high doses of ginger can cause ginger burn. It's kind of like acid reflux, except it's ginger. It's the ginger product. And when that happens, and it can worsen acid reflux. When that happens, you just drink it with a lot of water, or it might not be for you. So those are the prokinetics. Now, prokinetics for gastroparesis are typically used with meals 3 times a day. For SIBO prevention, so this is after you've got the SIBO cleared, you're either 80 to 90% better, or you have a negative retest. Then you start the prokinetic after your treatment, right after your treatment, and it's used to prevent it from coming back, because by clearing out the bacteria, you have not addressed the underlying cause, the deficient motility or the obstruction or the deficient immune system or whatever else might be there. So we use the prokinetic as sort of a stimulant of the motility that we can do until we know how to fix the motility.
Yeah, and I want to speak for a lot of people who potentially have, maybe cancer survivors too, because I know that the odds of cancer are extremely prevalent now, as is SIBO. And so a lot of people are going through chemo, and some of these things can be really disastrous to the migrating motor complex, potentially long term. So I'm asking for myself, I'm asking for everybody else who's gone through a lot of assault on the migrating motor complex until we know exactly what the root cause is. Once we're at that point where we're in remission of SIBO and we've cleared, like you just mentioned, how long would you recommend taking these things like the iberogast or the ginger or any of the antibiotic type of prokinetics? Would that be something we take? I would imagine not so much the erythromycin as much, maybe the LDN or maybe the ginger, some of the things that are less assaultive. How long should we take those for?
Yeah, well, really, it's such a good question, and there is no clear answer. Dr. Pimentel put forward an algorithm, a treatment strategy algorithm, where he suggests 3 months as a minimum after you finish your SIBO treatment, successful treatment. And then what you can do is, at any time, you can do a trial removal. However, I want to also say that Dr. Weinstock has stated at the symposiums that he feels if you've had SIBO for 5 years or longer, you're going to need to be on prokinetics for a long time.
Yeah.
For many people, it's going to be a forever thing, because their SIBO is a forever thing. For instance, scleroderma, diabetes. There are many diseases that cause SIBO are going to continually cause SIBO. Many people have it chronically because their underlying cause cannot be treated or reversed. So for them, it's going to be ongoing. For many people, it's going to be ongoing. Even erythromycin and prucalopride, though many people are doing those long term. But at any point, a person can do a trial removal. And the way I suggest doing that is to do a slow titration down so you can catch a relapse if it happens before it fully hits you. So I would go to using it, maybe you would cut your dose down for a little while, or maybe you'd go to every other night. You'd go to every other night, I'd say for 3 weeks, maybe a month. You don't have to do it that slow. It depends on the case, the person. People's personalities some of them are an all or nothing, so they're just going to want to not do it slow.
Right.
I'm speaking for the people who've had a lot of trouble with SIBO, who really don't want to relapse. They have very strong feelings about it. So in that case, you're going to want to go slow. Then, after some time of going every other night, you'd want to go to every 2 nights, etc., etc. I've had a lot of people do that, and they do begin relapsing. And then what we can do is we can just bring back the prokinetic to full dose, and we often can stop the relapse without having to retreat with antibiotics or herbal antibiotics.
Awesome.
So that would be the point of going off of it slowly is to catch it if you relapse.
Yeah, I don't ever want SIBO again. So I eat a lot of ginger, and I used to think it tastes like soap before, and now I've just learned to like it. Maybe it's because my body has associated it with a good thing. I don't know, but I don't ever want to look 5 months pregnant again unless I ever decide to have a baby. So I don't know about you guys, but
this is amazing that you I mean, you're doing quite well with just eating ginger. There are people who will not need prokinetics forever, that their migrating motor complex heals, or whatever it was that was underlying it is healed, and they don't need prokinetics anymore. I've seen a few of those cases. I don't get to see too many of them because I'm specializing, so I see more of the tough cases, but there are people like that. In fact, Dr. Pimentel, on that interview, you were just saying he had done an interview with Chris Kresser, and he talked about the rate of relapse, and it was, you know, somewhere in around a third of people will be able to not need prokinetics long term, and will be taken care of by their treatment, and they're not a chronic patient, a chronic SIBO patient, a third. So that's pretty good, you know. But 2/3, the majority, are going to be a little bit more difficult.
Yeah, and as you mentioned, the longer the SIBO has been around, the harder it is going to be to treat, and the longer it will take. And there's one thing I wanted to mention, in starting to close up here, that everybody's asking this question now because he mentioned it, is that before we were saying that the diet and eating low FODMAP, which is, you guys will, you know, we're not going to get too deep into it, but we already did sort of a little bit, but we'll have the checklist below and what exactly low FODMAP means, but that it's a good idea to eat low FODMAP when we're treating, because it actually gets the bugs more active. And so they're
eating high FODMAP.
I'm sorry, yeah, eating high FODMAP instead of eating low FODMAP.
I actually have a very strong experience with this. And I did speak with Dr. Pimentel about it because it's a different experience than he has had. So I think it's a fine thing to do to not change your diet. If you're just new to SIBO, you're getting diagnosed, you have not changed your diet, then I think that's a good idea. Don't change your diet. Don't go low carb when you first treat. However, and then that would be in alignment with what he's suggesting. Keep feeding the bacteria. However, when Dr. Pimentel recommended this at the first SIBO symposium, lots of doctors tried it with their patients, and lots of patients tried it on themselves. And these are patients that I'm talking about who had been on a restricted carbohydrate diet to treat their SIBO for some time, quite some time. And so what they did is they thought, well, maybe if I treat with antibiotics or herbal antibiotics, but now I increase my carbs, it will be more effective. And after that SIBO symposium, I received just an overwhelming amount of feedback from doctors and from patients telling me that not only did that not work, but it really made them worse. And I did share this with Dr. Pimentel. So
you're saying, just to clarify, eating the high FODMAPs while treating with rifaximin and neomycin,
or herbal antibiotics.
Okay, so it didn't work. It's the opposite of what he said on that show.
Yes, but this is a select group of people. These are people who were already on a restricted carbohydrate diet for quite some time. So I feel that advice might be dependent on patient population. And I will say that I haven't experimented intensely with this. It was feedback I was receiving. So I really was just contacted by an overwhelming amount of people to say that really didn't work for them. And it didn't, like many doctors have contacted me to say they just had failure after failure by doing that with their patients. But upon questioning, these are people who went off their low carb diet to increase carbs during treatment. So I just would say that at this point, my experience is that if you have not gone on a low carb diet, I would agree with Dr. Pimentel, and don't go low carb on your first treatment. Stay with what you're doing. And this is why if somebody comes to me they're a new SIBO patient, which I don't get to see too often these days, I mostly see failures, but if they're new, I do not put them on a SIBO diet until after they've done their antibiotic or herbal antibiotic. And even then, I'm not going as strict, because now we don't even need to go as strict because they've just had treatment.
Right.
So that's what I'm doing. I know that's what Dr. Morenstein's doing and many other doctors. However, it's a different circumstance if someone comes to you. I mean, I see people who've been on very restricted GAPS or SCD for 7 years. People come to me, I've been 7 years, I eat 5 foods, I eat 10 foods. Those people, I don't think increasing the carbs during treatment works for them. They have an unsuccessful treatment, you know.
Okay.
So now, like I said, I did share this with Dr. Pimentel, but, you know, just hearing it from one person, he might not have decided he takes that in or believes that. So I can just offer what my experience has been.
Absolutely. No. And I'm glad that you said that, because this is another one of those windows of opportunity for us to go, okay, it's always case dependent. So there's like no absolutes, and everybody's looking for the answer, the silver bullet. And we all just have to realize that our treatment is going to be different, especially with the 85,000 different chemicals in our food supply. And we've got all these different things that could be happening inside of the body, and the bugs are getting smarter. And it's just, we just don't know. And that's why working intimately and independently with people just helps, because it gets, I just remember so many times just being in tears, like, when will this bloat ever go away? Like, just wanting to one time go on a date and be able to wear a flattering, you know, hip hugging dress where I wasn't insecure, and having to hold it in, and then having the worst gas and the worst pain when I got home. And like, God, if he only knew that we were on a date, I was just holding back a million farts that whole time. It's just, it's humbling, isn't it?
Yeah, and you bring up such a good point. Whenever anybody's wanting to affect their health, when you're at the start of it, when you're a patient and you just want help, or if you're a doctor and you're beginning your practice, you're in your earlier years, everybody's just looking for the one answer, the one pattern. And life isn't like that. People aren't like that. We're very individual, and it's like very frustrating, and gosh, I'm so sorry, but there aren't easy set patterns for everybody. And that is the point of a doctor or a healthcare practitioner. That's why you go to them. That's the point of our job, is because we individualize to the person to the best of our ability, and don't just slap a cookie cutter on them. Because anyone, you can just write on a blog or find something out there, some easy patterned protocol, but that's why you work with someone, is to have it individualized to you.
Yep, absolutely. It's the trend of healthcare, and I think it's a good direction for everyone to take, because the Googling anything is overwhelming these days. So I want to ask one final question. Speaking of customizing things, everybody asks me the same question with regard to SIBO, and just in general, is there one? How do we know what best probiotic works with SIBO, or even to combat SIBO, or just for us in general? I know there's spore-based probiotics, there's soil-based probiotics, there's dairy-based probiotics. So which?
We absolutely do not know. There's absolutely no answer to that. And that is the best example of the individuality, because people have such a very different microflora from person to person. And so we absolutely don't have an answer. I'll just give you the brief overview, which is that the clinical experience of folks like Dr. Pimentel conflicts with what the studies are showing on probiotics. The studies on probiotics are showing that they are beneficial for SIBO. Many, many good studies. And they're just using your basic, dairy-based probiotics that you get in any, Lactobacillus acidophilus, Bifidobacterium bifida. They're just using your standard old, regular old, there's a few slight differences, but when you look at the studies as a whole, it's nothing special, and they're showing good results. However, in clinic, Dr. Pimentel, many of my colleagues, and even myself, often find them to be very aggravating. And so here, more than any place, I think it's case by case. I absolutely have seen patients that probiotics really help them. I have absolutely seen patients that probiotics really aggravate them, really are wrong for them. And then the vast majority is in the middle, where they do maybe a little bit of help or not much. It is just case by case. I really don't think, I think it's okay to experiment, just like with food. I really think if you try it for a day or two, and it's not, you've noticed something's wrong, it's aggravating you, just stop it and you'll be okay. It's like, it's not like you're going to put yourself back years and years or something like that. It's okay to give it a go, because, many people are benefited, and then others are not. The concern here with probiotics is that if you have an obstruction, if you have a partial obstruction, if you have deficient motility, won't more bacteria just accumulate? It's a very valid concern. However, there are other ways probiotics work. Sometimes they actually stimulate the migrating motor complex, and studies are showing good results. So it's case by case. What I do is I ask each and every person, how have you done with probiotics? And we have to sort out, have the probiotics had prebiotics in them, FOS, MOS, GOS, because that directly aggravates SIBO. We don't want those. And then we just take it from there, and we case by case, the whole situation, we decide whether we want to do them now, whether we don't. I do it different with every person. Back to your original question of strains, there's absolutely no studies on SIBO with anything other than the basic strains. So there's no spore studies, there's no soil studies. So the basic ones have shown good effect. I didn't review my probiotic material for this talk, but I can tell you that I've done a lot of study on probiotic strains for IBS, and there were a few that stood out. One of which is Bifidus infantis, and that's the one that's in Align. Align helps a lot of people. You can get Bifidus infantis in other products, but Align itself, which is bought in the drugstores and has some kind of crappy ingredients in its base, like sugar and talc or something like that. Many patients find that one works better for them than other products of Bifidus infantis, and that particular one, Align, has been studied and shown to have good results. So, and this is even patients that are very opposed to the base ingredients that are in there have actually found it, in my experience, have actually found it to work better than other versions. Another one is Lactobacillus Plantarum is quite helpful, and Bifidus lactis. Those are strains that across the board in IBS studies, not particularly in SIBO studies, have shown help with bloating, constipation, diarrhea, pain. And we can, that's a whole other, I can pull out my report, but we're kind of at the end here. So yeah. That's all kind of a whole other talk is, which strains. But basically my original answer really stands that we really don't know.
Yeah. It's like a whole world.
And you had sent over some questions ahead of time for the listeners, and one of them, very astute questions, one of them said, what about, would the probiotics be different for hydrogen versus methane? I think that we will find out that is going to be true. I think so, but I don't know what those strains are.
Yeah, no, it's so cool. I mean, the power of I don't know yet, or the power of we're doing our best. And so I think, what's important is to stay on top of these. And I think it's so great that you're doing all these interviews with health practitioners like myself and doing symposiums, because this and hypothyroidism, from my research, is probably in the whole industry really is so much is changing and so quickly. And it's all really interesting, and it fascinates me, and it gets exciting, but I know for the listeners, it's getting more confusing. So, I mean, even for us, it's getting more confusing. So there's like all these different things, but it's like more power, more knowledge, but more confusion, because the answer is always now going back to, it's all about what works for you.
Yeah, which is a frustrating answer. I mean, there are some quick basics we can wrap up so we don't confuse people too much.
Good idea.
I'll just give you some quick basics that there's more risk factors, meaning more things that could contribute to cause the underlying causes of SIBO than we could even probably write down on a piece of paper. However, what is really the underlying causes are deficient motility in the small intestine, and some sort of mechanical problem or partial obstruction in the small intestine, and frank immunodeficiency disease. There are other things that could contribute, but those are the main ones we know for sure. Quickly how to treat it. You need something to kill and get rid of those bacteria. So whether that's herbal antibiotics, or we didn't talk about it, but elemental diet, that's another option. And how do you use diet? So those things will kill it when you're done killing it, which can take some time. You might need multiple rounds, and maybe the particular item that you chose isn't a good match for your bugs, and you have to try something else. But once you get there, prokinetics afterwards. I even use prokinetics after each round to hold any gains we've made. So that's a very important piece, is not to forget the prokinetics. How long is at least 3 months, maybe long term. And then how to use diet. Diet is really the best thing about diet, and you could use various forms of low carbohydrate diets, like the one that I compiled that's a combination of SCD and low FODMAPs plus my clinical experience is SIBO Specific Food Guide. There's SCD, there's GAPS, there's low FODMAP, there's Dr. Pimentel's low fermentation cedar cyanide diet. It doesn't matter. Paleo, there's whatever. So long as you reduce your carbs, you're going to be affecting your symptoms. I think the best way to use diet is for symptom control. That's really the best thing. I haven't seen diet be able to remove the bacteria out of the small intestine, meaning give a person a negative test and remove all their symptoms in very many cases. In some people, it does give them like 100% symptom relief. Great. Maybe they don't need to do anything else then, for God's sakes, you know. But if it doesn't do that for you, I mean, that's wonderful if diet does that for a person. If by chance it doesn't, then, you know, you're in the majority of people, you just use it for symptom control, and it's all about balance. You have to balance between how restricted you're going to be with the problems that causes, you know, weight loss, nutrient deficiency, and unhappiness. So that's where you mix that symptomatic control treatment with the other treatments. And diet is also helpful for prevention. So just not keeping some pulled backness on the carbs, along with a prokinetic, and spacing meals if you can 4 hours apart are important for prevention. So that's just my little overview to try and keep it somewhat simplified. All the little ins and outs of how what a person does on their treatment, you know, whether they want to use probiotics or not, that's case by case. If you're struggling, you got to mix it up. But that's the overview.
Oh, no, that's great. And I basically took notes, and it's what I plan to include in the guide for everybody so they can just have it in their hand and try it, and maybe they can present it to their doctor for some support. Is just the first thing is awareness and observation that you've got something going on, and you're being honest with yourself, and then you're going into discovery and experimentation. What might aggravate it? Maybe you remove gluten for a little bit. Maybe it's just that. Then you have confirmation that you've done some lab testing. Maybe you did that with, you know, health practitioner, functional or allopathic, either one who you trust is really important in your journey. Then you go through the treatment and you work with your doctor, health practitioner, do that. And then you have prevention. So it's all those steps. And I plan to have that in a downloadable guide that by the time you guys are watching this, that you guys can download that and you can work with it, because like Dr. Allison said, everybody's different. And so this is what we need to understand and adopt about medicine moving forward, is that the treatment's not always going to be the same, and the studies are not always going to prove what's right for you. Mm-hmm. So awesome call all the time. I mean, I always have a million other questions because you just provide such great, succinct answers, and it leads me to another rabbit hole over here. But the next rabbit hole will be on women, specifically moms who are going to they're looking to have a baby because people are asking, is it healthy to have a baby while they're treating for SIBO? I mean, there's a lot of really good questions that came out of this call. And thanks to everybody who participated in the questions that I've posted in the forum. And anytime you need a person to interview you, I'd be more than happy to. Because I just so if you're like, I have a million questions that I really want to get through, and you want someone to interview, I always love doing these. We can make it even more, you know, maybe even in person one time. So that'd be cool. But SIBOinfo.com, you guys, there's a ton of information on there. I'm going to put everything below anyway for you. And Dr. Siebecker is in the process of writing a book right now too. So it's really hard to stay on top of, I would imagine, all the new research and keeping it all in one book, right?
Near impossible. It's why I've been working on it for 5 years, and I will get it done. I will.
She's trustworthy, you guys. She's telling the truth. Okay, guys, thanks so much for tuning in. If you guys have any questions, you can reach out to her on her website, or you could obviously reach out to me too. We're more than happy to help and get you the answer for you as quickly as possible. So battle the bloat and find out what your mystery is. Okay, guys, thanks for tuning in. See you guys later. Keep the bow down.